Welcome everyone. This is at Physio McMurray, and today's presentation is going to be on plantar fasciitis. Hopefully a lot of runners are going to be watching this presentation and might find this presentation useful for sort of heel pain that they could be suffering with. So in this presentation, I'm going to be defining what plantar fasciitis is. I'm also going to discuss the risk factors that put you at risk of developing this injury. I'm also going to describe how a physiotherapist can diagnose it and the treatment that a physiotherapist can give you for this condition. I'll also talk about differential diagnosis. So these are conditions that are similar to plantar fasciitis that you might get confused about. So defining plantar fasciitis. So plantar equals is the bottom of the foot. So as you can see in the picture there, fascia essentially is connective tissue that supports sort of every organ and everything together. So so fascia kind of holds your muscles together. You have fascia everywhere, and this fascia you have in the bottom of your foot. So that's the plantar fascia. This fascia connects the heel bone to your toes, as you can also see in the picture. So the term fasciitis is kind of unclear because the itis part of the word suggests that there is inflammation, whereas this isn't strictly true. It's actually there isn't any like sort of your traditional inflammation where I don't know, if you roll your ankle and you get massive swelling. There's just a little bit of thickness of the tissue, but there isn't that kind of liquid inflammation that you see. So for this reason, it's now called plantar fasciopathy. So that kind of just means pain in the plantar fascia. So you might have been told that if you have this pain, you probably have a heel spur that's causing it. You might do, but it's not actually that very frequent. So only about 50% of people that have pain in their heel actually have a heel spur. And many people with pain don't have a heel spur. So even if you have one, it doesn't mean you're going to get pain. And if you do have one and you have pain, it doesn't mean that's the cause. So yeah, this is I literally just put plantar fasciitis into Google, and this is the first image that came up, and it has the heel spur. So it's probably going to be quite misleading if you're just going and Googling plantar fasciitis. So the risk factors. So it's more common in people aged 40 to 60. It can be sort of change in hormones. If you're a female, that can cause risk factors as it kind of makes your sort of tendons a little bit weaker to change the load. So if you're increasing your running and you've got change in hormones, it puts you a little bit more at risk. If you spend a lot of time standing up, so recently I had a hairdresser came in who was spending hours and hours standing up. She got plantar fasciitis, and then this is also a problem because in the treatment you want to decrease the load, so you want to decrease the pain that's in their foot, but if their job requires them to stand up all the time, there's not really much they can do about that. So overtraining is probably the biggest thing that runners need to think about. So like with most tendons and those kind of structures, if you're increasing your load, i.e. you're running intensity and mileage or volume too quickly, then your tendons aren't going to be able to react in time for that change in load. So to a cellular level, they lay down weaker collagen that they can produce quicker to try and keep up with your load, but that weaker collagen can't take as much load, and then you get a bit more pain. So biomechanics can also play a role. So as you can see in this picture here, you shouldn't be able to, if you're looking at someone's foot, you shouldn't be able to see the other side of the floor, so that they have a really high arch, and this sort of characteristic puts you at risk of getting plantar fasciitis. Similarly, if you get tight calves, this calf is sort of Achilles tendon is kind of connected to the plantar fasciitis. So if you have a tight calf, it's going to be pulling on the plantar fasciitis, which could cause the risk of getting injury. And then obesity as well can be an issue, due to increased load. If you're heavier and then you go for running, it's going to be increased load. But not only that, but fat cells sort of secrete certain chemicals that can weaken your tendons. So now we'll move on to the diagnosis. So you'll know if you have plantar fasciitis when you have pain in the morning. So you get out of bed, and then the first thing, you put your foot on the floor and it feels really sore and tight. And then you give it a little stretch, and then you walk around for a bit, and then it gets better. And that's a classic sign of plantar fasciitis. Likewise, if you have an office job and you're sitting down in a chair for a long period of time, and then you for a few hours, and you get up and then it's a little bit sore, and then after a while it eases off. That's a classic sign of plantar fasciitis. So if you're a runner, you'll find that it's sort of painful at the start of the run, and then as you ease into it, it gets less sore. Palpation, so that is when you're feeling the actual tissue itself. So if you prod it with your finger right on the insertion on the bottom of your heel, that is where you'll get pain for plantar fasciitis. You may also get pain if you sort of prod up the arch of the foot where the plantar fascia runs. So yeah, so that's where you get the pain if you have this condition. The pain is more sort of localized, but if you have it for a longer period, so if it's lasted for a couple of months, then it probably becomes a bit more widespread. If you recently increased your training load, so if you're a runner and you know that you've transitioned from running on soft ground and doing longer sessions in the winter, and then you're switching your training to track training, and then you're sort of running on the track more, you're running quicker, faster reps, and then you get this pain. So that's probably a good indication that you've got plantar fasciitis. And there is a test that you can do called the windlass test. So what you do is you'll put your, if you're sitting in a chair, you can put your ankle onto your knee, and then you'll stretch your toes upwards, and then sort of do that with your ankle, so your toes are pointing up. If that reproduces pain, then you could have plantar fasciitis. However, this test isn't very sensitive, so you could have plantar fasciitis, but then it doesn't actually cause pain. So that's what sensitivity means. So if the physio isn't sure, they can get you an ultrasound. So say if you have weird other symptoms that are a bit weird that could suggest it's something else, or if you've had it for like a long time and it's just not responding to treatment, then the physio may get you an ultrasound. So the ultrasound will basically show that your plantar fascia is thick, so thicker than the other side, or what's considered normal. And the thickness may be the cause of pain, but there's people that could have an ultrasound with a thick plantar fascia, but they don't actually have any pain. And it's also not a linear relationship, so you could have the pain in your plantar fascia, they ultrasound it, they find that it's thick, and then you do your rehab, you don't feel any pain anymore, you get it ultrasounded again, but then it's still thick, so the thickness doesn't actually equal pain. And that's also it kind of means that you shouldn't re-ultrasound it, because you might worry that it's still thick, that means that the pain's going to come back, but that's not the case. So I wouldn't bother, if I were you, having another ultrasound. If your symptoms get better, then that's the only thing you really need to worry about. Okay, so you figured out that you've got plantar fasciitis, or your physio has diagnosed you with plantar fasciitis, and now you're moving on to treatment. So the first step in treatment is to decrease your pain sensitivity and to sort of modify what you're doing, so activity modification. So say if you've got a job where you have lots of standing, it might be an idea to talk to your boss to try and change your roles so you can spend a bit more time sitting. Or if that's not available to you, say if you're hairdressing, you have to stand up to cut hair, maybe see if you can change your setup a little bit. So maybe see if you can wash the hair sitting down, or see if you can change your space so you can sit down where you're cutting hair. Or maybe have a stool where you can rest your foot on and put your weight onto the other leg. If your weight is an issue, maybe start trying to lose some of that weight, so look at your diet. Diet is also important because it helps sort of decrease the inflammatory markers, so It's important for tendon healing anyway. And then try and increase your activity in other ways. So maybe you can try swimming where you're not putting weight through that plantar fascia. And then if you're a runner, so this is probably more specific to people watching this, but if you're a runner, the most important thing you can do is to have a clear rule on the pain you're putting yourself through when you run. So the most important sort of rule to go by with tendon issues is don't go above a 4 out of 10 on the pain scale. So every time you do running or any form of activity, you want to keep it a 3 out of 10 or lower. So that means, say if you're going for a walk for 10 minutes and it's only a 2 out of 10 pain, then that's fine. You can carry on doing that. And then you wake up the next day and it's still only, and there's still no pain, there's only 2 out of 10 pain, then that's fine. But say the following day after that, you go out for like a 30-minute walk with a dog, and then the 2 turns into a 7, that is a no-no, because that is going to cause you to irritate your plantar fasciitis, and it's not going to heal. And likewise, it could be 2 on the walk, but then when you get back, it goes up to 7. That again isn't ideal. So you want everything you do during the activity and after the activity for the next 24 hours has to be below a 4 out of 10. So what you can do with that is you find your threshold. So you found that the maximum you can walk without causing it to go above 10 is 20 minutes walking. So you would keep doing that for a few days, and then when you feel like you might be able to progress it a little bit, maybe walk for a few minutes longer, see how it feels. If it doesn't get any more painful, then that's fine. Do that for a few more days and then add a few more minutes. So go up to like 25 minutes, and there's no pain of that, go up to 27 minutes. And then just keep incrementally increasing it without increasing the pain. And that is the best way to sort of manage the plantar fasciitis without like quitting running altogether. Okay. So what actual exercises can you do in the treatment for plantar fasciitis? So you can start off by stretching the plantar fasciitis. So if you put your foot on your other knee, so it's like that windlass test I was talking about the other in the previous slides. You put your foot on your knee, and then you stretch your toes out. And what you can also do is put your toes up against the wall and then bend your knees to the wall. So that will stretch your Achilles and your plantar fascia at the same time. So what you can do when you're stretching is kind of 10 seconds of light stretching, 10 seconds rest, 10 seconds of light stretching, 10 seconds rest, and do that 10 times. And you want to do that as much as you can throughout the day. So 3 times a day is quite good. Obviously, if it's painful when you stretch, it goes back to the same rule as before. If it's above a 4 out of 10, try not to do it. Just stretch really lightly. So don't pull your toes back so far, only pull it back as far as where it doesn't cause any pain. And then the next, once everything's settled down and it's not as painful, you should start doing some low resistance exercises. So you should start off with isometric. There's been a few studies that show that isometric contractions can actually reduce pain. So an isometric contraction is essentially when your muscle isn't moving. So the classic example is when you get your arm up into the air and then you just tense it. So that would be an isometric contraction. Whereas if I had a weight in my hand and then I'm lifting it up like this, that is a isotonic contraction, because my muscle is actually shortening. So the isometric contraction, where your muscle doesn't, where your joint isn't moving, the one you can do for this is called a heel stand. So you'll put your feet on the edge of a step. So this is your heel. And then you're basically just holding your leg in that position, so you're not letting your heel drop down. What you can do is try and just hold your heel off the edge of the step for 45 to a minute, or 45 seconds to a minute, and then do that 2 or 3 times. It's probably best to start doing it with both legs, and then as you progress it a little bit, you can then do it on the one leg that's sore. Another thing you can add in that kind of adds a little bit of a stretch to the contraction is putting a towel under your toes. So when you're sort of standing there, it has a little bit of a stretch component to it. Once isometric exercises are comfortable and you can do it on one leg and hold it for like a good few minutes, then you can start to add heavy slow resistance training. So that is where you do the isotonic contraction. So what you do is, rather than just holding your heel there, you'll go up onto your toes, but you'll do it really, really slowly, and try not to aggravate the muscle. So you probably start off just doing it with 2 legs, and then when that feels comfortable, progress onto the 1 leg. But yeah, I'll probably wait till you can do sort of 20-30 reps 2 legs comfortably, and then go onto the 1 leg, and then build up again to the 20-30 reps and a few sets on the 1 leg. And then after that, you can put on a rucksack, put some weights in. Maybe you can use like cartons of milk, milk cartons full of water. You can use like rice or something, and then use that as a way to increase the load on the muscle. Another thing you can do is strengthen the intrinsic foot muscle. So if you imagine this is my foot, and the intrinsic muscles are the ones that kind of run inside the foot around here. So they help hold the kind of arch of the foot like this. So essentially they are supporting the plantar fascia, like stopping that doing all the work. So one way you can strengthen intrinsic foot muscles is if you put your foot on a towel, and then you're just going to scrunch the towel up with your toes, and that just helps build up those muscles there. Cool. And then this capacity versus load is essentially like an explanation that physios use to describe why you're getting plantar fasciitis pain and why strength exercises help. So essentially, you have like a cup here. So if you imagine you have a glass of water, and that is the load you can handle, and then the water in it is how much work you're putting through your tendon. So the cup is the load that your tendon can handle, and the water is the actual load itself. So every time you go for a run, you're going to be pouring in more. Oh, here's my drawing skills. So every time you go for a run, you're going to be pouring in more and more water, and it's going to be increasing the load. Once that cup overflows, so once the water comes out, that's basically you injured. So you've got your cup, you go for a run, you put some water in, and then you go for another run later that day, put some more water in, you go for a run the next day, put more water in. This cup's now overflowing, so that means your tendon can't handle the load, so now you're injured. So essentially, you want to increase either the size of your cup or decrease the amount of load in there. So by reducing your running to stay below the 4 out of 10 pain, you're reducing how much water is in there. So you're reducing the load on your tendon. By doing the strength work, what you're doing is you're increasing the cup size. So you're increasing how much water you can put in there, because as your muscles get stronger, they can handle more load, which means the cup size increases. So it's kind of, you're hitting both sides by having the strength work increases this, and then you have decreasing your running total, running intensity and volume decreases that, and that is the way that you treat plantar fasciitis. Okay, so what is the prognosis? So the prognosis is kind of the likelihood that you're going to recover and how long is it going to take. So it can vary depending on how many risk factors you have. If you've had the injury before and it's recurring, if you're old, if you're young, if you're male, if you're female, but it normally takes a few weeks to a few months. So you have to make sure that you know what to expect, because if you're expecting it's going to just become better in a week's time, you're going to start running again, and it's just going to come back and get worse, and it's going to ruin your motivation, and you're just going to not stop enjoying running. So you have to sort of realize that it might take a few months for you to keep doing rehab and then get back into the running that you want to do. The research also shows if you have this kind of pain, you don't get it treated before 7 months, then they have a worse they have more of a long-term prognosis. Men also have a better prognosis than females. And then if you have pain on the one side, that is better than having pain on both sides. If you're younger than 40, you actually have a worse prognosis, but I'm not sure on the reason why behind that. And then my face is covering the the words. But anyway, you may be told that you need corticosteroid injections to treat this, but essentially you can do if nothing else has worked. But I wouldn't go use that as a first line of treatment. And there's been a study that shows that a corticosteroid injection is no better than just a placebo after 4 to 8 weeks. So a placebo is like a sham treatment, really. And there's also a risk with corticosteroids injections because the steroid itself kind of thins all the structures. So obviously, if your tendon's thinning, then there's more chance of it rupturing. But I myself have been listening to podcasts and things like that, and most medical professionals haven't actually ever seen a corticosteroid cause a tendon rupture. But it's just a risk to consider if you plan on getting it. So, differential diagnosis. So just to recap, this is conditions that look similar to plantar fasciitis, but they aren't plantar fasciitis. So then the first one is one that's probably quite common in runners, especially females that suffer from REDS and things like that, is a stress fracture. So you would know it's a stress fracture when you have pain at rest. When you have plantar fasciitis, you shouldn't get pain at rest. And another way is if you're palpating or prodding the bone, then that's probably more of a stress fracture than plantar fasciitis. You may get a little bit of a swelling. The second one is a fat pad atrophy. So we'll go through this later, but you basically have like a pad of fat on the back of your heel that it just helps sort of cushioning as you're walking around and running. But it's fat pad atrophy when and also atrophy means reducing in size. So where hypertrophy is like increase in size, you'd probably know from if you read things about like muscle bodybuilding. So say muscle hypertrophy is putting on muscle mass. So atrophy is reducing size. So your fat pad gets thinner. So it's fat pad atrophy when the pain's worse the longer you walk. So if you remember, I said with the plantar fasciitis, walking should actually make it feel better, whereas it's the other way around with the fat pad. Also with plantar fasciitis, you have more of a pinpoint pain where you're prodding it. But if it's fat pad, it's more diffused, kind of all around the heel, and it's normally kind of right on the bottom of the heel. So it's like right on the very base, bony bit of the heel, whereas plantar fasciitis would be a little bit more forward, where the plantar fascia attaches onto. A third one is neural pain, so that is like nerve pain. So you commonly get this around your tarsal tunnel. So that's on like the inside of the ankle, and you'll sort of have neural pain. So you might get pins and needles, a bit of numbness, like weird sensations. So that's the way you differentiate it between that. And then the last one is Achilles tendinopathy. So I think most people would have heard of this, but it's the insertional version. So you can get a tendinopathy kind of in the middle point. So imagine this is your Achilles tendon. And then this is where it attaches onto the bone. So that's the bone there. So you'll get an insertional tendinopathy here, where it actually attaches onto the bone. And then the midpoint is here, where it's in the middle of the tendon. So this one down here may feel like plantar fasciitis because it's kind of on your heel. So some people may get confused. But the way you differentiate it is on the back of the heel, whereas plantar fasciitis will be underneath your heel like that. Cool. So fat pad atrophy. So this happens more frequently in females over the age of 50. If you get it in when you're younger, it's probably more acute, sort of acute pain. So it's probably like trauma why you've got it. So you might have fallen off a ladder, landed on your heel, and then just sort of damaged your fat pad. Whereas if you're older, it's probably just come around spontaneously over time. The pain's a bit more diffuse, so it's kind of just in all that area all around here. But clinically, you're most commonly going to find it painful right at the bottom there, whereas plantar fasciitis would be in this area as it goes across kind of there. So that's where you would find the plantar fasciitis pain. And then that bit there is the fat pad pain. So you get pain, in the center of the heel, and it's more when you're walking. Over time, it doesn't get better; it gets worse. You'll probably want to have an ultrasound to confirm this. So the ultrasound will see the thickness of the fat pad and where it's thinned. And sometimes what they'll find is it's moved either side. So your fat pad kind of will go this way, and then it would also kind of move this way, so it'll thin right on the bottom there. So yeah, and then if you have repeated corticosteroid injections, as mentioned before, they thin the sort of tissue around that area. These can increase your risk of fat pads. So, if you've had like 3-4 injections, you may develop this. So if someone's getting heel pain and they've had that, I may look more towards the fat pad. So what is the treatment for fat pad? So you'd want to tape it for a few days. So taping essentially will help support the fat pad. So you probably what you do is you'll squeeze the fat pad together. So you'd like squeeze it in that way, and then that way. So essentially you're thickening it up rather than it spreading around. You're thickening it back into that middle part, and then you're going to tape it in place so it just supports the cushioning in that area. You can use sort of soft insoles or like heel pads. So if you imagine that the foot's in a shoe, you'll just put a soft heel pad in this area here that just sort of helps the cushioning, so it kind of does what the fat pad's meant to do. And then you just have to be very conservative. So strengthening isn't going to make this better because it's not an issue with the tendon or the muscle. So you want to rest it to sort of allow the fat pad just to decrease its inflammation and recover essentially. Okay, so the next one is neural irritation, so nerve irritation. So if you have sort of nerve symptoms like the pins and needles, numbness, like weird sort of sensations in the medial side of your ankle, then you might be diagnosed with what's called tarsal tunnel syndrome. So it's tarsal tunnel syndrome as it's the nerve gets entrapped within the tarsal tunnel. So the tarsal tunnel is basically a little area under sort of the medial or the inside of your ankle that certain structures run through. So you have tendons, you've got a nerve, the tibial nerve, and you've got arteries that run around your ankle down into your foot, and they're held into place by this structure called the flexor retinaculum. So retinaculum is basically, it's kind of similar to fascia or like a ligament, but it's basically like a ligamentous structure that just runs from your heel bone to your ankle bone, and just holds all these things down in place. So it's kind of like a little space these things run through, and if it gets entrapped or compressed, then the nerve will just sort of get irritated, and then it will sort of fire like weird sensations. So that's what will cause the pins and needles numbness and weird sensations, because it's getting entrapped. So it's just getting a bit irritated. So what you'd feel is you'll get pain during rest and kind of like night pain. It'll be sore if you palpate this inside bit here. So that medial malleolus, that is literally like the big round thing at the inside of your ankle. And so you just drop off that, and then if you sort of prod and poke and tap this area, that will replicate the pain. So tapping that area is actually a test called the tarsal tunnels test. So you'd sort of get the ankle and you sort of tap it like this, and then if you get the pins and needles and numbness when you're doing that, then that's a positive sign. You'd also get pain up the medial side, so the inside of the ankle going up there. If you put your ankle in a weird position, it can stretch the nerve. So if your ankle's going to be going up like this, so if you imagine you're dorsiflexing it, or like going like this, then it's going to stretch the nerves that way. And then if you're going to point the ankle outwards, then you're going to be stretching them sort of like the other way around. So that'd be inversion. So that's your ankle there, you're kind of like pushing it like this, and it's going to be stretching the area around here where the nerve runs. So when you're stretching it, it'll irritate it even further, and then it will bring on your symptoms. To diagnose it properly, or well, not properly, but more accurately, you can use an EMG. So yeah, that just sort of tests the nerve conduction. Okay, so what are the extrinsic causes? So these are causes that are outside of your body. So these are the things that you quite easily change that will have could have a good effect on your symptoms. So if you have poorly fitted shoes, so if they're making your ankle collapse downwards, so you might get a bit more supported shoes. If you're tying up your laces too late, could have an effect because it's kind of compressing this area in there. If you've had a trauma, so I don't know, if you've had, you've twisted your ankle and it could have caused swelling in that area, and then the swelling compresses the nerves, which then cause that symptoms. Or if someone's like played football and someone's kicked you right on that area and they've just like kicked onto the nerve. And then if you have sort of biomechanical abnormalities, so if your heels collapse inwards, then it's going to be causing more strain in that area. So that's another thing. If you get more better fitted shoes, or if you can use insoles to correct that, so you can keep your ankle sort of in a neutral position, that would be one way to fix that. And then post-surgery, so if you've had surgery in your ankle, I don't know, maybe you've I don't know, ruptured your Achilles tendon, or I don't know, broken a bone or something, this scarring that's left behind after the surgery could basically just sort of reduce the area or the space in this area, and can just cause a bit more compression. Cool, yeah. And then what are the intrinsic causes? So you'd have tendinopathy could cause this issue. So as you can see, you've got a tendon here called the posterior tibial tendon. So that is the tendon that kind of runs down this loop here. So if this tendon becomes weak and sore and painful, and it gets tendinopathy, it will enlarge slightly. So that enlargement could decrease the space in this area, which could then cause compression on the nerve. Likewise, when you get tendinopathy, you get a bit of inflammatory markers, so not swelling, but just markers of swelling. But that could just cause the nerve to get irritated and then cause some pain. If you get tenosynovitis, so that is kind of similar to tendinopathy, but you have like a sheath that goes around the tendon, and that is where you can get sort of swelling in that sheath area. So that could cause pain in the tendon by the inflammatory markers causing that pain, or the increased size of the tendon decreasing the space in that area. And then you can get osteophytes. So if you have osteophytes, are basically parts of the bone that grow, bone growth that grows out when you have osteoarthritis. So osteophytes are the kind of thing that the classic osteoarthritis in the knee have, where you can when you can sort of feel the hard bits on the side of the joint. So if you have this in your ankle and they're growing out onto this area here, they could just be impinging onto that nerve there. Cool. And then if your retinaculum is really thick, then it's going to decrease the space and it could compress on there. Cool. Yeah. And then if there's different levels of severity, but if the space decreases quite a lot, then you could get arterial insufficiency. So you can see there's the posterior tibial artery, and then you'll get sort of ischemic pain, so like a deep aching kind of pain in the foot, and it may start to feel cold, and those kind of things. So what is the treatment if you get this neural irritation? So it's rest, because you want to stop irritating it. You want to slowly grade walking back in, so it's similar to the tendon. So you want to make sure that you're not overworking it and just going to keep on irritating it. So you want to work off your pain threshold. As mentioned before, orthotics to help with the biomechanics of the foot. Stretching doesn't really help because it's just going to stretch the nerve and irritate it. Strengthening probably isn't going to help, because it's like for short term anyway, because it's not like a weakness issue. But long term, if it's going to help with your biomechanics of your ankle, then strengthening is probably something to look at later. There's a treatment called neurodynamics where essentially you're trying to move the tendon in and like up and down its course, so like the sheath it's in, to try and release adhesions. So one way you can do that is by stretching. So imagine this is the tendon here, and you've got one end here, and you've got another end here. So if you stretch this end, what you're going to do is you're going to be stretching the tendon, the nerve, which is going to cause pain. But if you stretch that end and then relax this end, rather than the nerve getting stretched, it's gonna move that way in its sheath, if that makes sense. So you can move it this way by moving it that way, and then if you move it the other way, you're sort of moving it up and down the sheath. So you stretch that way, release that way, and then you can do the opposite. So it would go release that side and then stretch this side, and it moves the other side. Probably not the best explanation, but how you do that is, so say my nerve running down my arm, if I straighten my arm, that is going to stretch it that way, and then if I bring it this way, it's going to loosen it this way. If I move my head this way, or so that way, it's going to stretch it this way, but if I move it this way, it's going to loosen it. So what you would do is kind of so stretch my arm and then relax it on my head, and then stretch my head and then relax it on my arm. So my nerve is kind of going up and down. So it's going that way and that way, that way and that way. This is a really common treatment. Well, previously this has been a really common treatment to treat nerve pain, but the research isn't really too strong on it. But I've used it before for other for like sciatica and stuff, and it seems to be okay. So it might be something to work. It's not exactly going to cause you any harm, so you might as well give it a go. You can use sort of painkillers. So you can use non-steroid anti-inflammatories. So that would be like ibuprofen. And if that doesn't work, you can use medication that is more specific to neuropathic pain. So like gabapentin, pregabalin. I wouldn't use these for too long. Try it for like a week or two just to decrease the acute pain. But yeah, I wouldn't, unless it's really bad, I wouldn't bother using these. And then obviously if it's really severe and you have like really severe compression, then surgeons can use decompression surgery. So what they'll do is with this retinaculum, they'll just cut it a little bit, so it's not as tight. So if they loosen it off, it just adds a little bit more space in this area. And there's actually found to have quite good results with that surgery. Okay, so yeah, that's it. I think don't worry about all those differential diagnosis sort of slides. If you have any queries or worries about them, then just make sure you go and see like a therapist. But yeah, so essentially, plantar fasciitis is pain in the bottom of the foot that eases with activity. It's normally sore after waking up, but then it will go as you walk around. If you have any other symptoms, or if you're worried that you might have the other things that I've discussed, then go see a therapist. It may take a few months to improve, so just don't don't try and progress it too quickly, and don't get annoyed if it takes longer than you think. You can still run, just keep the pain below a 4 out of 10. And then with the rehab, start with light stretching, and once your pain decreases, introduce the strength work. And then and then after you've got the strength work on your biomechanics, and then slowly increase your mileage. Okay, thanks for listening. This is at Physio McMurray. These are my social media sort of accounts. So if you want to have updates on presentations I'm doing and articles I'm doing, then just follow me on here. Thank you very much.